All right, what's going on, everybody? This is Ethan again from MP Crash Course, and today we're going to be talking about appendicitis. So I took a look at the previous videos that I've done, and I decided to just add a little bit more information from going forward. So hopefully it could be a little bit more detailed, and you guys will be able to understand the material a little bit better, especially when you are in practice. So when you guys take a look at this video, just let me know how it is and give me your thoughts and comments and see what I can do to make it better in the future. So, but if you gonna like this video, just like, comment, subscribe, and we'll start now. So, what is appendicitis? So the appendicitis is inflammation of the vermiform appendix, and that is often due to obstruction by a fecalith, lymphoid hyperplasia, or foreign body. And so obstruction leads to increased intraluminal pressure, bacterial overgrowth, ischemia, and possible perforation. So the appendicitis is most common in adolescents, young adults. So here we're going to take a look. It's more of like an overview. So when you're gonna have the obstruction, there's an increase in intraluminal pressure, venous congestion leading to ischemia, bacterial invasion leading to inflammation, then to necrosis and perforation, and then perforation leading to peritonitis. Now let's take a look at the epidemiology and risk factors. Most common in ages 10 to 30, slight male predominance, Western countries, especially when it comes to low fiber diets. And for children and elderly, there's an increased risk for perforation. Now let's take a look at the classic signs and symptoms. So you're going to be having periumbilical pain migrating to the right lower quadrant. That's also known as the McBurney's point. And so you're going to have nausea and vomiting, typically following the onset of the pain. Anorexia and low-grade fever are common, and pain worsens with movement, coughing, or palpation. So here are some of the key physical exam signs. So you're going to have right lower quadrant tenderness at the McBurney's point, a positive Rovsing sign, which is right lower quadrant pain when you palpate the left lower quadrant. You're going to have a psoas sign, and that is the right lower quadrant pain with hip extension. And then you're going to have the obturator sign, which is right lower quadrant pain with internal rotation of flexed thigh. And then also rebound tenderness and guarding. And so when you have that rebound tenderness, that may be suggestive of peritonitis. So just be aware of this. Okay, so when it came to the psoas sign and the obturator sign, I kind of figured that it's kind of like a little difficult to know what it looks like. So I got some pictures. So when you have the psoas sign, you're gonna have the leg extended. You're gonna have the leg extended, and then when you extend that leg, then that patient is going to feel the pain in that right lower quadrant. And so with the obturator sign, now the obturator sign is basically you are going to lift up the right leg, and then when it is at a 90-degree angle and the patient is lying supine, you're basically going to have the ankle be turned laterally and then the knee turning medially. So what that does is that's going to put pressure on the appendix through the obturator muscles. And so that's going to cause the pain. Okay, so let's take a look at some of the pertinent labs for appendicitis. So you have white blood cell count elevated at more than 10,000. And normal, remember, is 4,000 to 10,000. And if it's perforation, it might be around 15,000. But there's going to be an elevation of the white blood cell count. So CRP often elevated at more than 10 milligrams per liter, and just remember the normal is less than 5, and it can rise within 6 to 12 hours. Neutrophils can be more than 75%, bands more than 5%, left shift. Bilirubin may also rise as well. And then when you have a urinalysis, there might be mild pyuria or hematuria, and then electrolytes, hypokalemia, and alkalosis if the patient is vomiting. Okay, now let's take a look at the imaging. So imaging, you have ultrasound. So that is pretty much preferred in initial tests with children and pregnancy. Again, with children, if you want to do a CT scan and contrast, I know there are some providers and NPs who do CT scans of children. Just know that with that much imaging in a child, it can increase the risk of blood cancer. So just be aware on what you feel like you want to do, an ultrasound or a CT of the abdomen. And then additionally, with the CT of the abdomen, it's going to be most accurate in adults, and the findings it's going to be have an enlarged appendix that's going to be more than 6 millimeters, wall thickening, fat stranding, and appendicolith. Okay, now let's take a look at the differential diagnoses. So some differential diagnoses you can put down are gastroenteritis, ovarian torsion, ectopic pregnancy, pelvic inflammatory disease, UTI or pyelonephritis, mesenteric adenitis, Crohn's disease, and renal colic. But when you're going to be doing the physical exam findings and you're going to be doing the imaging, it's pretty. You're going to know that it's going to be appendicitis, definitely. If you properly do the physical exam and you make sure the patient has proper imaging, then it's going to be pretty much you'll know it's going to be appendicitis. Okay, so stepwise diagnostic approach. HMP, you're going to have the classic presentation, and you're going to want to rule out pregnancy and genital urinary causes. Make sure you take a look at the CBC, CRP, and UA, imaging, ultrasound, or CT, and then surgical consult and supportive care. Now, one thing I do want to touch up on is where you're working at. So, for example, if you're going to be working in a family practice or in urgent care, so when it comes to a family practice, you have to do what's in your scope of practice in that facility. So family practice, they can't really take care of patients who have severe abdominal pain and possible appendicitis. So then if your hospital facility or your where you work at has an urgent care, then you can direct that patient to the urgent care, or you could direct that patient to the ER. It just depends on the facility you're at. So there are some facilities where you would have to do, okay, you're in family practice. Okay, this patient needs to step up in care, go to urgent care. And if urgent care can't really handle it, then they would have to go to the ER. Now, if a patient has perforation and peritonitis, then I would suggest ER. However, you just have to use your clinical judgment. Now, let's say you are just a completely separate building, a family practice. There isn't you don't have a urgent care right next to you, then I would suggest just contact 911. Patient has to go to the nearest ER. All right, so let's take a look at the treatment. So obviously the patient's going to have surgical management, laparoscopic appendectomy, which is the standard, pre-op, nothing by mouth, IV fluids, pain control, antiemetics, antibiotics, ceftriaxone, and metronidazole or cefoxitin. Now, if there is going to be a non-operative management, which is going to be in uncomplicated cases only, IV then to PO antibiotics, higher recurrence risk, just know that, and require close monitoring and informed consent. Some special populations to know about. So pregnancy is going to be atypical pain, so use an ultrasound or even an MRI. Children, ultrasound preferred. increased perforation risk. And elderly, there's going to be subtle presentation, increased complications. Okay, so for post-op care and follow-up in 7 to 10 days, wound care, watch for infections, signs such as redness, oozing of pus, etc. And if it's non-op, monitor for recurrence or worsening symptoms. So know about some common complications: wound infection, intra-abdominal abscess, ileus adhesions, bowel obstruction, and recurrent appendicitis if it's a non-op case. Okay, so let's take a look at the ICD-10 and EM coding tips. So ICD-10, K35.80 for no perforation, K35.2 with generalized peritonitis, which is perforation, and then 99204, 99214 for eval, and then 10160 for incision and drainage if needed. So make sure to document HPI, review of symptoms, physical exam, surgical referral if diagnosis is confirmed or highly suspected, and some clinical pearls. So remember, vomiting follows pain, not before. Always get pregnancy tests in females. A normal white blood cell count does not rule out, and early diagnosis prevents rupture. Some other things to note is that with patient education, so when patient education, you're going to avoid eating or drinking before surgery, importance of early intervention to prevent rupture, and then post-op care, educate the patient about post-op care, wound care, activity restrictions, signs of infection, and then make sure the patient knows about antibiotic adherence if managed non-operatively. And that is it. Thank you so much for watching. Make sure to subscribe to NP Crash Course for more quick clinical breakdowns. Remember to like, comment, and share if this helped you. Now, again, I kind of added a little bit more information. I tried to be a little bit more detailed when it came to the pathophysiology as well as differential diagnoses and as well as the labs. I kind of put a little bit more detail in the labs. So if it did help you, again, make sure to like, comment, and share. If it didn't, if you feel like something's off, let me know so that I can fix it in future videos. But other than that, that is it. Thank you so much for watching, and I hope you all have a good day.